So we will talk about all the things which includes the bones, the muscles, the viscera, the division of the thorax into different subcategories. So first of all, we have the thoracic cage. So with the thoracic cage, we need to understand that there are two things which are very important. One is the superior thoracic aperture known as the inlet, and second is the inferior thoracic aperture or known as the outlet. So what are the boundaries? So starting from the posterior end, we have the first thoracic vertebra, then we have the curvature of the first rib, and then at the anterior aspect, we have the manubrium of the sternum. This is the boundary of the inlet. Similarly, in the outlet, posteriorly we have the 12th thoracic vertebra, then we have the 11th and 12th rib, and then we have the costal margin, and in the center anteriorly we have the xiphoid process. So all these areas, when united in the form as could be identified from the specific color lines, they identify the specific areas as inlet and outlet. Now, regarding the thoracic wall, it has sternum, 24 ribs, and 12 thoracic vertebra. Now, regarding the muscles, there are two types, the intrinsic muscles as well as the extrinsic muscles. In the intrinsic muscles, we have the intercostal muscles, subcostalis, and the transverse thoracic muscle. Whereas among the extrinsic muscles, we have the pec major, pec minor, serratus anterior, and subclavius. Now, we will go into the detail of sternum. So it has the manubrium, which is this area. Then it has the body, and at the end it has the xiphoid process. So there are multiple joints which are present with respect to the sternum, and we need to know not only their names but also their types. So first of all, we will have the manubriosternal joint, which is over here, which is a secondary cartilaginous joint. Then we have the xiphisternal joint, which is a primary cartilaginous joint. Then in this area, there is going to be sternoclavicular joint, which is with the clavicle, which is going to be like over here and between the sternum. This is the example of the synovial saddle joint, whereas the first joint, which is formed between the sternum and the rib, known as the sternocostal joint of the first rib, it is different because it is a primary cartilaginous joint, whereas the remaining joints between the second to seventh rib, they are the example of the plain synovial joints. So next very important thing with respect to sternum is the presence of these levels because they are very important. So the start is at the T2 and it extends till T9. The important thing is that at the junction of the manubrium sterni, there is this level known as the T4, T5 level. Now this area is very important because a lot of landmarks are present and you need to know all of them, which includes it is a demarcation between the superior and inferior mediastinum. It is a landmark for the bifurcation of the trachea, bifurcation of the pulmonary trunk, starting and ending of the arch of aorta, formation of superior vena cava, azygous vein entering into superior vena cava, and the thoracic duct crossing towards the lateral side at T5 level. We will talk about this when we talk about thoracic duct as well. But you need to know all these important structures which are having its relationship to this level, that is of the T4 and T5. So next up we have the thoracic vertebra. Thoracic vertebrae are classified into typical and atypical. Regarding the typical, they are going to be a heart-shaped body. It is going to have a lamina, a pedicle, and a spinous process. So this is going to be the body of the vertebra. These are the superior and inferior facets which are going to make joints with the vertebra above and vertebra below. And there is going to be the pedicle and lamina, and this is going to be the spinous process. Now, as we cannot see on this area, but there is going to be a lateral process as well. I will explain this in the next diagram. So the unique thing is that it has multiple facets and it is going to form multiple joints. Whereas the atypical thoracic vertebrae include T1, T10, T11, and T12. And why they are atypical? Because they have only single facet on their body. So that is the differentiating point, and these are the numbers which are important to know, that these are the four thoracic vertebrae which are atypical. Rest of them are going to be typical. So what are the different joints which are going to be formed? So this is a cross section where you can identify that this is one vertebra. Now it is going to form intervertebral joint. That is going to be, again, the types are very important. That is the secondary cartilaginous joint. Then it is going to form the joint with the vertebra at 2 points. As you could identify from this, that this is going to be the costovertebral joint, and this is going to be the costotransverse joint. So this is between the transverse process and this area of the rib, and the main area of the rib making articulation with this thoracic vertebra is going to be the costovertebral joint. So the costovertebral and costotransverse, both of these joints are the synovial plane joints. Now these are the ligaments which are very important. Uh, Here we have the anterior longitudinal ligament, then we have the posterior longitudinal ligament, then we have the ligamentum flavum, and then we have the interspinous ligament between the spines, and then we have the supraspinous ligament. So again, sorry. So again, we will see that which are the ligaments. So here we have the anterior longitudinal ligament, which is present on the anterior aspect of the body. And similarly, on the posterior aspect of the body is going to be the posterior longitudinal ligament. And then this is the spinal canal area. At the back of it is going to be the ligamentum flavum. And then these ligaments are present between different areas. Now, the ligament which is present between the transverse processes is known as the intertransverse ligament, and the one present between the spinous processes is known as the interspinous ligament, and the one which is extending above or from the superior aspect of the spinous processes is known as the supraspinous ligament. Then we have the ribs. Ribs are classified into true, false, floating, or typical and atypical. Regarding this classification, rib 1 to 7, as identified by red color, are the true ribs. From 8 to 10 are the false ribs, and 11 to 12 are the floating ribs. Now, what makes it typical and what makes it atypical? So ribs from 3 to 9 are typical ribs. Their head has two demi-facets, and they have a neck, tubercle, angle, and shaft. Now, out of these, angle is the weakest point, which is the area where most of the ribs get their fracture. Now, regarding the shaft, it is important that on the inferior aspect of each shaft, there is an area which contains the neurovascular bundle that includes the vein, artery, and nerve. So there is going to be this is area that is the shaft, and then this area is going to mark the angle, and then this is going to be the neck, and then this is going to be the head, and in between that area there is going to be a tubercle. Now regarding the atypical, the first rib has a single articular facet. It is shortest and most curved. It is horizontal, and it has scalene tubercle. Now this is a feature which can be tested, that which is a specific feature or a different feature with reference to the first rib. It has a scalene tubercle. Now second rib has a roughened area for the serratus anterior. 10, 11, and 12. Now 10, 11, and 12 have a single articular facet, and the 11th has no tubercle, and the 12th has single facet but has neither tubercle nor it has any subcostal groove. Now regarding the thoracic wall. Now I have explained these muscles, but out of this there is a very important concept, that this is going to be the external intercostal. Then we have the internal intercostal, and then we have the innermost intercostal. Now the concept is that between the internal and innermost intercostal lies the neurovascular bundle, number one. Number two, it is present in the sequence of vein, artery, and nerve. So you need to know both these things because they're frequently tested. Now, regarding their function and their placement. Now, you need to know this sequence. However, rest of the things are not much important. You can take your time and try to add Netter's diagram and identify where they are going. But the most important thing out of all this is their function. So external intercostal is responsible for forced inspiration, whereas all the rest muscles are important for post expiration. So that is the difference that you need to know. Now, regarding their placement, there is an important thing that external intercostal are present antero-inferiorly, whereas and innermost intercostals are present posterior-inferiorly. Now, next up, we have the diaphragm. So, what is the attachment and what is the innervation of the diaphragm? So, diaphragm has a three-planar origin and insertion. So, starting from here, these are the cruras. As you could see from the left side, it has origin from the L1 and L2, whereas on the right side, it is going to have origin from L1, L2, and additionally, it is going to have from L3 as well. Now, then we are going to have these coastal areas which is attached to the coastal margin of the lower sixth rib, and along with that, those ribs along with their coastal cartilages. Now, in the center, it attaches to the or it inserts to the xiphoid process of the sternum. Now, regarding the diaphragm, it is innervated by the phrenic nerve, which has values C3, C4, and C5. This is the motor innervation that is responsible for the inspiration and expiration, whereas the sensory supply is in addition to the phrenic nerve, the lower intercostal nerves are also responsible for the sensory supply. Now, the next important concept with reference to diaphragm is its openings and which structures are passing from the openings and at which level. So, at the 12th thoracic vertebral level, aorta, thoracic duct, and azygous vein are going to pass, and it is named as the aortic opening. Okay, and then we have the T10 level that is known as the esophageal opening because through this passes esophagus, the two vagal nerve trunks, and the left gastric artery. And then we have the T8 or the vena cava opening through which passes the inferior vena cava and the right phrenic nerve. So there is a mnemonic that says that I8 10 eggs at 12. So in this way, inferior vena cava is at level 10, level 8, esophagus is at level 10, and aorta is at level 12. So next up we have the pleura. So as you could appreciate from these different colors, I have divided them into different types. So this orange color identifies the visceral pleura, which is going to be strongly adherent to the parenchyma of the lung, whereas the parietal pleura has different types. Now, the one which is labeled as yellow is the cervical, which is the area which is present in close relationship to the neck of the body. Then the pleura, which is labeled as blue, is the costal pleura because it is going to be present underneath this costal cartilage rib cage. And then this green is known as the diaphragmatic one, because it is present on the diaphragmatic surface. And then this pink one is the mediastinal pleura because this is lining the mediastinal wall of the this area which is containing the pleural cavity as well as the lungs. So next up we have that which of the pleura is supplied by which nerve. So this is very important. So costal parietal pleura, which is forming this area behind the costal cartilage or the rib cage of the thoracic cavity, it is innervated by the intercostal nerves. Now, this area which is present on the medial side, it is supplied by the phrenic nerve, Diaphragmatic parietal pleura, which is this part, is supplied by the phrenic nerve as well as the lower sixth intercostal nerve, which is actually the same supply of the sensory part of the diaphragm. Then we have the visceral pleura. It is supplied by the pulmonary plexus of nerves. Now then, regarding the pleural recesses, we have two of them. And what are the recesses? So what is the recess? Recess is a potential space which is present in this rib cage. Now we have two of these. We have the costo-mediastinal recess and the costo-diaphragmatic recess. The costo-diaphragmatic recess is present in this area, which is present between the costal pleura and the diaphragmatic pleura. As you could appreciate from this diagram, that this is present between the costal as well as the diaphragmatic pleura in this area. And then we have the costo-mediastinal. It is present between the costal as well as the mediastinal pleura. So it is going to be present on this side. This is going to be the mediastinal surface, that is this, and this is going to be the costal. So it is, and there's an important concept that it widens on the left side more prominently as compared to the right side. So next up we have the basic anatomy of the lung. We have the surfaces and the borders. So regarding the right and left lung, we have that area which is in close relationship with the rib cage is making the costal surface. Then the area which is in relationship with the diaphragm is the diaphragmatic surface. And in the last, the medial area, which is siding the mediastinum, is known as the mediastinal surface. Now, in addition to this, there is some borders, and this is the anterior border, which is quite sharp for the right lung. Then we have the inferior border, as you could appreciate from here, and then we have the posterior border. So there are three surfaces and three borders which are important. You can take your time and review this diagram as well. Now, regarding the lobes and the fissures of the lung. So in the left side, we have two lobes named superior and inferior. As you could appreciate that this will be the superior and this will be the inferior one. Okay. Now, on the right, we have three lobes. We have the superior, we have the middle, and we have the inferior lobe. Now, there are two types of fissures which are present in this area. Now, in the right lung, we have two fissures, but in the left, we have only one. As you could see, that this fissure is running from the inferior border towards the posterior border and is going to be present. It is going to run on the posterior aspect and it is going to continue with the posterior border. Now, horizontal fissure runs transversely, as you could appreciate from this. Now, the area where it runs is very important. It runs from the sternum at the level of fourth rib. So that is frequently tested. And then it unites with the oblique fissure over here. So this is going to be the horizontal fissure. And here is going to be the oblique fissure. And these fissures are actually dividing the medial lobe of the right lung as well. So next up we have what are the structures which pierces this hilum of the lung. We have the bronchus, which you could appreciate that this is the trachea. It is going to divide into right and left main bronchus. Then we have the pulmonary arteries. Now this is the pulmonary trunk. It is going to divide into right and left pulmonary arteries, which are two in number. And then we have the bronchial arteries and veins. So they are going to be given off by the descending thoracic aorta in this area. And in addition, there is going to be presence of pulmonary autonomic plexus and lymph nodes, which are very important constituents of almost all the areas such as hilum and various other areas. Now, the lung is going to have a dual blood supply, that is from the pulmonary as well as bronchial. The clinical importance is that in case if there is some pathology, that is the pulmonary embolism, the patient can survive because lungs are the area where oxygenation occurs. And if there is a pathology of a severity, that is pulmonary embolism, it can kill the patient. It will make it very difficult for the patient to breathe. So, in the presence of the dual blood supply, the clinical picture can be masked, and the patient can survive with if this condition is managed appropriately and within time. So next up we have the lymphatic drainage of the lungs. Now it is divided into superficial and the deep. Superficial lymphatic plexus is present just beneath the pleura, like over here, and the deep are going to be present around the blood vessels which are present in the parenchyma of the lung tissue. Now, what is the pathway? So we will start from here. It is going to be the intrapulmonary lymph node. They are going to go from within the lung to the hilum. That is going to be this area. And here they will enter into the bronchopulmonary lymph node. Now, from the bronchopulmonary lymph nodes at the hilum, they are going to enter the tracheobronchial lymph node, which are present at this area. That is the bifurcation. From here, they are going to ascend upward into the paratracheal lymph nodes, which are present beside the trachea, which are eventually going into the mediastinal lymphatic trunks, which are going to open into the brachiocephalic vein. So this is very important. Now, in the left side, there is an additional thing that all these lymph nodes from the left side will first of all open into the thoracic duct, and then thoracic duct. Uh, if, for example, this is the left side, there will be the thoracic duct and it is going to come over here. So on the left side, these all lymph nodes will enter this thoracic duct first, and by the means of this thoracic duct, they are going to enter this brachiocephalic vein complex over here. Now, regarding the bronchopulmonary segment, so what is the definition? So it is a portion of the lung which is specified by a specific segmental bronchus, its artery and vein. So functionally separates the region of each lobe, and both the right as well as left lung has 10 bronchopulmonary segments. So they are wedge shaped. Their apex is at the hilum and the base is at the surface. Now the importance is that they can get occluded or they can get damaged in atelectasis and bronchiectasis, and they are very important specifically during bronchoscopy, that which area needs to be seen during a bronchoscope, and for surgical resection, if there is a tumor involving any specific area, we can highlight it and we will only remove that area rather than removing complete lung or more than that area. So next up we have the tracheobronchial tree, its origin, insertion, and various important things. So trachea start at the level of cricoid, that is C6, and then it is going to end at the level of Lewis, known as this, that is the T4 and T5, which I have explained previously. So it is going to divide at this level, which is going to be T4 and T5. Now from here, it is going to divide into right and left main bronchus. Now these main bronchi are going to divide into the secondary bronchi known as the lobar, and then the segmental, which are the tertiary bronchi, which are going to enter into the conducting bronchioles, which are going to form the terminal bronchioles, and then we will be having the respiratory bronchioles. We will have alveolar ducts, and at the end over here, we will have the actual alveoli, which are going to provide a single membrane area for the gaseous exchange. Now, regarding the bronchi, their level is very important. So, on the left, we have T6, on the right, we have T5. Now, important clinical correlate with the right-sided bronchi is that it is shorter, wider, and less vertical. So, any foreign body which is coming inside is going to go more on the right side. So regarding the angle of the carina, it is 60 degrees in the adults, and it is present at the level of T4 and T5 in the mid respiration. So regarding mediastinum, this line which was present at the T4 and T5 has divided the mediastinum into superior mediastinum and inferior mediastinum. Inferior mediastinum is further classified into anterior, middle, and posterior. So there is an important concept that you need to know which are the structures which are present in which part of the mediastinum. In the superior mediastinum, we have the trachea and esophagus, the aortic arch and its branches, superior vena cava and azygous arch in terms of veins, thoracic duct, and vagus phrenic and recurrent nerve. So, if you try to memorize them in such a way that you identify that which is the viscera, which blood vessel, which vein, which structure, and which nerve is present, it will be very easy for you to memorize. So I have added this with different colors so that it will be very easy for you to remember if you add this diagram on your notes. So in the anterior, the structure is thymus, the blood vessel is internal thoracic artery, vein is the internal thoracic vein, and we have the parasternal lymph nodes. Whereas in the middle, the structure is the heart with its great blood vessels, ascending aorta, pulmonary trunk, and the pericardiophonic artery. Whereas the veins include superior vena cava, the pulmonary vein, and the pericardiophonic veins. And when the nerves, we have the vagus, phrenic, and the sympathetic trunk. In the posterior, we have the esophagus, thoracic aorta, azygous, hemiazygous, and accessory hemiazygous veins, thoracic duct, vagus nerve, and sympathetic chain. So you need to know all these structures, and they are very frequently tested in the MCQs as well. So next up we have the pericardium. Here we have the layers of pericardium, which is fibrous and serous, and I will explain this with the next diagram. So as you could appreciate that this brown color is the fibrous pericardium. Beneath that, this first blue is the parietal layer of the serous pericardium. Between or below this is the actual pericardial cavity, and below that will be the second layer, that is the visceral layer of the serous pericardium. So first of all, we have the fibrous pericardium, then the parietal layer of serous, and then pericardial cavity, and then we have the visceral layer of the serous pericardium. And beneath that, we will have the myocardium and endocardium. So regarding the blood supply, we have the pericardiophonic artery, internal thoracic and musculophrenic artery, which are branches from the subclavian artery, and direct branches from the thoracic aorta, which supplies the heart. In terms of innervation, the pericardium is supplied by the phrenic nerve, which has root values C3, C4, and C5. Now we will talk about different structures of the heart. First of all, we have the right atrium, which you can appreciate from this area. So the inflow into the right atrium is by the superior vena cava and inferior vena cava, and by the coronary sinus on the posterior aspect. Now, its blood is going to enter through the tricuspid valve into the right ventricle. So you need to know that which area is bringing the blood and what is the direction of the blood. Now, by means of the crista terminalis, the cavity is divided into two parts, a smooth part, which is posterior, and a rough part, which is the anterior. Now, it has these muscles known as the pectinate muscles, which are actually the muscles forming the walls of these atria. Now, in between the right and the left atria, we have the fossa ovalis, which is closed in the later part of the life, but it is another name for the interatrial septum. So next up we have right ventricle. Now through this tricuspid valve, blood is going to enter into this area. Now it will be filled, and after this it will go in this direction. Now this direction of the blood that is going to be, it is going to enter into the pulmonary trunk, which is later on dividing into pulmonary arteries. Now again, the right ventricle is divided into smooth part, which is near the infundibulum, which is the dilated part just below the pulmonary trunk, and this rough area. Now this rough area has multiple structures. Now the cusps of the tricuspid valve is attached by means of the chorda tendini into these papillary muscles. These are the papillary muscles, and these are the very thin strings which are connecting the cusps of the tricuspid valve to this area. Now, their importance is that when the blood has entered this area, they will keep the valve closed, and when the blood is supposed to enter from this right atrium to right ventricle, they will open it. So there is a very well coordinated movement of these papillary muscles in relationship to the opening and closing of the valves. Now, here, this area that is thickened is known as the moderator band area, that is also known as the septomarginal trabeculi. Now, this is again a very important diagram. So, I have added another one. So, this is the leaflet of the valve. These you can appreciate are very thin strings. These are known as the chorda tendinae, and they are attaching these leaflets of these valves to these areas which are known as the papillary muscles. So the number of cusps or number of leaflets, the same number is going to be present for the papillary muscles. So for the tricuspid valve, there are going to be 3. For mitral, there are going to be 2. And for atrial as well as pulmonary, there is going to be 3 for each of them. Now, next up, we have the left atrium. With left atrium, we have 4 pulmonary veins which are going to bring the blood to the left atrium. And by means of this mitral valve, the blood is going to enter into this left ventricle. So you need to know the flow, that it is being entering by means of these 4 pulmonary veins, and then it is going to into the left ventricle. Now again, it is divided into a smooth posterior part and an anterior rough part, and it has the pectinate muscles which are forming the wall of the left atrium. Then we have the left ventricle. So the inflow is by means of the mitral valve, and the outflow is going to be through the aorta. Now, again, it is divided into 2 compartments, the smooth and the rough part. Now, the rough part has the trabecula carni. And again, as you could appreciate that here we have the papillary muscles. Then we have the chorda tendinae, which are attaching these cusps to these areas so that there could be a coordinated movement. Now, there is an important thing that the thickest myocardium is of the left ventricle. So that is an important thing. So regarding the valve, so the tricuspid valve has an anterior, posterior, and a septal cusp. And out of these, anterior is often the bulkiest and septal is often absent. Now, these are connected to the papillary muscles by means of the chorda tendinae, which I have already explained previously. Now, they keep the valve closed during the relaxation phase, during the ventricular systole, that is the contraction phase, so that the reflux of the blood from the left or right ventricles to the atria can be prevented. So that is why they are attached very precisely to the specific muscles. Then we have the mitral valve. It has anterior and posterior cusps, and again the function is the same, and it is attached in a similar fashion to these papillary muscles. So you need to know these number of cusps and what are their names. Like we have anterior and posterior for mitral, and we have the anterior, posterior, and septal for the tricuspid valve.